with our group at the from the DoD, we attempted to include an ivermectin including arm in the trial that we have pending with the agency as an IND right now, but the FDA raised so many objections and asked us to do some fundamental studies about demonstrating the mechanism of action of ivermectin, that the Department of Defense decided that it just wasn't worth the delay in time to get the trial started, and so they dropped the ivermectin arm. So the landscape right now for the therapeutics and prophylactic drugs looks like I'm going to stick my neck out, but I'm in close contact with Andy Hill, who's doing the meta-analysis. I've seen the work of Tess Laurie, that's now published, another meta-analysis from worldwide ivermectin data. I think the data keep getting stronger and stronger in favor of ivermectin as having some protective activity within a safe dosing range. And that seems to be impacting in various emerging economies that don't have access to vaccines, and is impacting on event rate for severe COVID disease and death. So there's some great kind of epidemiologic studies or data coming out of India where Indian states had been on ivermectin, the incidence of attack rate of the disease was low. Then they withdrew it for political reasons. There was a change in regime, it went up. Then they re-implemented it, it went back down again, so that's pretty strong evidence. There is also reasonable evidence for the use of ivermectin as a therapeutic, but there are many others, and it's just the one that has gotten a lot of press, in part because of Pierre Corey's Senate testimony. So ivermectin, and then a whole host of anti-inflammatories, because what folks often don't understand about COVID is that we have the SARS-CoV-2 virus infection event. And typically that leads to a disease of varying severity at something in the range of 4 to 7 or 8 days afterwards. But that disease only happens in a subset of patients, maybe 80%, maybe 50% of patients, taken across all age groups, maybe even less. And the disease is the hyperinflammatory response to the virus. So the disease is really our reaction to the virus. The good news is with drugs is that we have this rich library of anti-inflammatory drugs that appear to be quite useful against keeping people out of the hospital if it's used early enough, or treating them once they're in the hospital. The antiviral that's been licensed, remdesivir, in the United States, the WHO is not recommending remdesivir globally, and many physicians in the United States find remdesivir to be of limited use in special situations. So the idea of antivirals for this is really not panning out, and there are multiple other antivirals that have been tested. This is often the case with respiratory viruses. So we all know about Tamiflu and influenza. Okay, Tamiflu in theory should be good, and maybe it has an impact, but you have to take it within 24 to 48 hours of first getting influenza. And during that period, often you don't know that you have influenza, so it's a little bit of a catch-22. Likewise with remdesivir, it appears. The other agent that has gotten a lot of attention is dexamethasone. That comes out of the recovery trial in Oxford. And that trial actually shows that the utility of dexamethasone is very limited. Now here in the States, a lot of docs have kind of gone all in, and you may even recall the president when he was infected, with even before, he wasn't that severe. And yet they put him on dexamethasone. Now the actual indication of dexamethasone, based on the recovery trial, is you should already be on oxygen, and high flow oxygen, or even intubated. So it appears that in the States, dexamethasone is being overused. This is often the case when dexamethasone is often kind of a first-line go-to when you have a new inflammatory disease. And then over time, additional agents come in that are more specific. And dexamethasone is dropped. Problem with Dex, is it's super nonspecific, and it hammers the lymphocytes. It hammers a lot of the cell populations that you actually need to recover from COVID long term. So cynics might say that Dex is a great way to get patients out of the hospital over the short term, but whether or not it's actually helping them over the long term, that's actually never been studied. So that's the landscape as I see it. The RNA vaccines obviously have gotten a lot of attention. They're remarkable. The adenoviral vectored vaccines probably produce more protein over a longer period of time. They came out fairly early and were identified as associated with coagulation problems. Those coagulation problems are now being seen more with the RNA vaccines. And there's a odd spectrum of symptoms, and the governments across the world have largely denied that there are any safety concerns with the RNA vaccines. That's now not so tenable. We had the CDC come out last week talking about the pericarditis and other cardiomyopathies that are showing up in the pediatric population, so this is up to the age of 18. And that is a significant safety risk. That was only recently identified about 2 months ago. It's taken 2 months for the CDC to verify it. There appear to be a number of other adverse events that are buried within the admittedly flawed databases that we have, that we're data mining to identify adverse events that are associated with the RNA vaccines. These include thrombocytopenia, also, so this is low blood platelets, and that can be associated with bleeding or other problems. Clearly, there is a signal relating to blood clotting abnormalities, again, as with the adenoviral vectored vaccines. There is cerebral venous thrombosis. That's a big fancy word, but what it means is blood clots in the veins draining your brain. So you can imagine that that's not a very good thing to have. It's kind of related to stroke. And I think that there's a good chance that we're having some of these cardiac symptoms exist in older age cohorts, but they are subject to what's called masking, which is this problem when you're looking at databases of epidemiology or whatever. If you have a confounding variable, like, for instance, certainly I am in an age cohort where cardiac events are not rare. And the problem is, if you have a relatively rare event associated with a drug or a vaccine, and it's in a cohort, an age population that has a high background for related things, it's really hard to pick out the stuff that's coming from the new drug as opposed to the background levels. That's masking. And so I think that it may turn out over time that cardiac signal that we're seeing in the adolescent population, we can pick it out because they have such a low background level. So there's very little noise. It's easy to see the signal. In older age groups where there's more noise, it's harder to find the signal, but a lot of cardiologists and others are reporting things that are making people uncomfortable. So with the RNA vaccines, it is remarkable, the level of activity. The technology has enormous potential, but there's these events, and it's a little odd. Physicians are starting to talk about the overlap between long COVID, this is these chronic symptoms that come after you get the acute infection. And by the way, you don't necessarily have to have the severe disease to get long COVID. Okay, these longer term adverse events and sickness problems that you can get after you get the disease. There seems to be overlap between those symptoms, that profile of symptoms, the disease associated symptoms, and the vaccine-associated symptoms. So long COVID, and some of these vaccine adverse events seem to have some overlap. And there are physicians that are claiming that they can actually do laboratory tests and show that they're having similar profiles in terms of laboratory abnormalities with these genetic COVID vaccine-related syndromes and long COVID. So there's things going on there with the vaccines. The problem is we don't know how severe they are in general. What is the bell curve distribution for severity and what's the incidence. And often the question is asked, why don't we? And the answer is because the FDA elected during this phase of emergency use authorization to not require that the drug manufacturers rigorously capture adverse events and efficacy signals. And so we end up relying on really outdated, antiquated systems that have been set up a decade or more ago, for the most part, or some systems that are self-reported like vSafe at the CDC, but those capture 1% typically of the events because they're all self-reported. And because they're self-reported, there are problems in interpreting those data because someone might say, well, Aunt May died 2 days after vaccination, and we're going to report this. And this is one of the big controversies, is there's a large number of deaths reported in VAERS, but they're not verified as being vaccine-related. And so there's a real arm wrestling going on about what do those mean, both in the US and Europe. So that's kind of where things are at right now as I see it. And then there's a whole cluster of issues around what would it actually take to get to herd immunity? And this push that 70%, often in many countries, Canada, for example, the government is saying we want 70% uptake of vaccine if we're going to release restrictions on a community or something like that. The problem is that we don't have any data from these clinical trials about the impact of vaccination on transmission. So you can't really make a real calculation to say epidemiologically how much vaccine, how many people within a population have to have either been infected or vaccinated. So that's kind of surfing the surface. There's a lot of other stuff underneath, but it's complex. It always is during an outbreak because there's never enough information.